Hey everybody, Doc Dave here. Just wanted to take a minute to talk a little bit about what this segment is all about. Tough calls, mental health, and the weight of responsibility. This is the reality of being a first responder, an EMT, a paramedic, and beyond. In this series, we take on a difficult conversation surrounding pre-hospital medicine and the unseen battles EMS workers face every day. We created this podcast series in memory of William Gabe Kleinschmidt, who was a good friend of mine and a roommate while I was in college. He has always been an advocate and a champion for mental wellness. Gabe struggled with depression and suicidal thoughts throughout his life, and despite his strength, openness, and dedication to helping others, he ultimately succumbed to them. His loss is heartbreaking, but his legacy lives on through those who continue his work. Through guest speakers, mental health experts, and the voices of those who knew him best, we'll explore the challenges EMS professionals encounter, their struggles, their victories, and the stigma that keeps too many suffering in silence. Our goal here is simple: to honor Gabe's legacy by fostering connection, breaking down barriers, and ensuring that no first responder, EMT, medic, and beyond feels alone in their fight. We also extend a heartfelt thanks to Gabe's family for allowing us to name this series after him. We hope to have them join us in the future to share more about Gabe and the lasting impact he has made on the lives of so many. If you have memories of Gabe or ideas for future topics, we welcome you to share them. Join us as we take this conversation forward and work toward a world where those who help others receive the support they deserve. Thank you to everyone for what you do. May God bless you, and know that we're always there for you. I hope you enjoy this segment.
The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions and ideas expressed are those of the hosts and guests and do not necessarily represent the views and opinions of any organizations we may be affiliated with. As always, follow your local protocols.
Hello, everyone, and welcome back to Medics, Musings, and Mayhem. I am one of your hosts, the medical director / EMS aficionado, ketamine evangelist, and POCUS evangelist, Dr. David Collins. A little weird doing the leadership on this part, but Phil is not with us tonight, unfortunately, but he may pop in segments, so keep an ear out for him. We are actually going to be talking about something very different tonight. In medical school at UND, we used to call this the touchy-feely stuff, but sometimes the touchy-feely is very important to talk about, and it's something that is worth discussing. But before I get into the why we are here tonight, I'm going to have our MS4 extraordinaire off to Denver emergency medicine very soon to be Dr. Regan Washist, introduce our new and hopefully ongoing recurring guest speaker, guest host, co-host, if you will. Who did you recruit to replace you?
I found an absolute wonderful human being to come join us. So with us tonight, we have Jason Kells. Now, Jason is a first-year medical student at the University of North Dakota. So I just found a mini student to come join. But he actually was in the field of EMS prior to medical school. And I'm talking critical care, NICU, SWAT, infectious disease responses. Like, he has so much experience in the field, and I'm so excited to get that insight into what we do here on the podcast and what we do with the protocols. So Jason, welcome. Thank you for being here. We love having you.
Yeah, so I got in the EMS. It was something that I just did on a whim. One of the local high schools where I grew up offered an EMT program. I wasn't an ideal student in my high school years, and so I decided I'd switch it up for a little bit. From there, I went and did my EMT and kind of fell in love with it and the being able to think fast on your feet. And then from there, I decided to pursue it further. I did a associate's degree in paramedicine up in the University of Alaska Fairbanks. And during that time, I was a on-call firefighter for a very small fire service up there. And then after that, I moved back to Minneapolis, where I completed my paramedicine and my bachelor's degree while working in one of the larger services in the Twin Cities. Was there for very just shy of 5 years. And then I got into medical school up here. Since getting into medical school, I've started 2 different ambulance jobs up here as well. One volunteer in the rural area and one at a slightly bigger urban center.
So basically, he's a glutton for punishment, is what I'm hearing. But everyone that I feel like gets into EMS or goes into emergency medicine, there's a high percentage, I would say, that get bit by the EM bug early, or they just want to learn more. There's a lot of people, I think, in EMT world and the paramedic world who wants to get out there, who wants to expand, who wants to make a difference in their communities. So awesome having you be a part of this team, Jason. I'm excited to have you here, get your insights. Let's talk a little bit about what brings us together tonight and a little background. In the communities that I've worked in recent months, we've had a lot of really challenging calls go out across different agencies, whether it's been trauma, cardiac arrest, car accidents. We had a tragedy involving the lake recently. So there's been a lot of really tough ambulance runs that have been going on as of late, which brought up some emotions and a lot of questions. And ultimately, what happened was I presented this question to the group, and the group shared my opinion that this is something that's worth talking about. Wound up reaching out to my own services and saw what opinions they might have about this topic. And I actually had a very heartfelt conversation with one of them tonight about their concerns, their frustrations. They recently had a very challenging event in one of the adjacent towns that I partner with and that I occasionally do transfers with or interceptions with. But it's something that we certainly cannot unpack in one night, but I think it's certainly worth discussing. And Jason, I think you've had an experience to kind of help maybe start the discussion, and we can kind of unpack it from there.
Yeah. So figured we'd start off this conversation the same way I kind of started off my EMS career. So I had my first cardiac arrest fresh out of medic school. I made it through 2 years on the fire service without one, all the way through medic school, through the clinicals without having any cardiac arrests, all the way up until I was onboarding at the larger urban area that I worked at. And I can still remember that day like it was yesterday. It was the end of our shift, and we were running to one of the suburbs. Cardiac arrest came across our CAD system. Initially, it came across as a 75-year-old female. And then from there, with the miscommunications that can occur with dispatch and high stress, we watched the number tick down 75 to 50 to 30 to 10 to 10 days, finally settling on a 10-day-old infant who is involved in a co-sleeping incident. Walking into that, my preceptors did the best that they could to prepare me for what we were about to walk into. Obviously, there's nothing that you can say in that instance to tell someone, especially I was 19 at the time, to tell a 19-year-old that you're about to walk in and see a dead 10-day-old. And we decided to work it in the truck and not in the family home. As we were making our way into the house, I remember my partner grabbing our kiddo and carrying out starting compressions on the run out. And then from there, a lot of the night was a blur. I still have these like occasional images in my head of working that call that night. The striped onesie and those numbers as we attempted to resuscitate in the back of the truck. Ultimately, we tried to transport to a large regional pediatric center with unsuccessful results, unfortunately. That was the start of my EMS career one weekend. And from that, we had the stem of my FTO, and I'll ever be forever grateful for taking me aside afterwards and being like, you're going to experience some things in the next week, in the next month, in the next year. And there's nothing I could do to prepare you for that, but these are some things that I need you to watch out for. And then the calls afterwards of her checking in and making sure that I was all right, especially as the thoughts of, well, do I actually want to do this kind of kept creeping back in and back in and back in over that, especially that next month as I was trying to get my feet back underneath me.
So obviously, in the world of emergency medicine, as an attending physician now and as a resident, we have our fair share of scary situations, right? The coding child, the young adult who's in a car accident or does something while they're drunk and stupid and they come in and we're trying to code and resuscitate them. But at least in most cases, for those of us in the emergency department, I've got a heads up so I can at least mentally prep myself for what's going on. What you've just unpacked, Jason, is, I think, what summarizes in a nutshell what people in pre-hospital medicine, whether that's, an ALS truck, a BLS truck, first responders. We had a tragedy a couple of years ago now that involved multiple children in a car accident, and they were very critically injured. And the people that were there were first responders. And I remember one of those individuals was thrown into a fire truck to get them to definitive care. So there's a huge difference between what I get on an ambulance page and then getting a report versus what you guys get on the CAD, for example. And I really feel like that feeling that you went through, and you can correct me if I'm wrong, that doesn't change. Whether you're 19 and you're fresh out as you're a baby medic or like a baby med student or a baby resident, you get thrown into who knows. Like this is something that's not as common in like pediatrics or OBGYN. This is something that's very specific to critical care, emergency medicine. Rural family practice might be another example as well. How do you think that went for you being 19 and trying to process that being a new medic?
I think you hit it right on the nose there, that no matter what age and experience you have, it kind of hits you pretty hard. The one thing I will say that I found interesting on my second one was that almost sitting on the precipice and waiting for the feelings to start up again afterwards, and knowing this is how it hit me last time. How is it going to affect me this time? And where is it going to bring me from here? I know that that first time kind of had that effect of I had no idea what to expect besides what was told for me. Given a lift, we did a critical incident stress debriefing that week, and I was handed a sheet of symptoms that was like, "Tell your loved ones to watch out for these." That's what besides what my FTO had told me, that's what I had to expect, was that sheet of paper. It was shaping. It was. It kind of gave me an understanding right from the get-go about some of the hardships that the career would have, but it showed me a lot. But I was, as I said, lucky that I had such great partners that night, and I was able to rely on them. And it showed me the effect and the positivity that you can get from that relationship with your partners, and that so-called sanctity of the truck that comes with talking about those feelings and how that affects you and where to go with those feelings from there and who to talk to and who not to. And
So let me ask you this, compared to when you were 19 versus your experiences now, do you feel like the support system has changed at all? Do you feel like any steps have been made? And I'm keeping this more in a general sense. Like, this is not to throw any agency under the bus. Like, this is a systemic problem, not just in the US. This is a worldwide issue when it comes to what pre-hospital medicine is. But have you seen any changes or any steps in the right direction, in your opinion? Or do you feel like overall you haven't seen much?
I saw actually a really large shift at the agency that I was working at. Right when I got there, they started doing a lot more of mental health initiatives and trying to get that availability for providers, for the ambulance providers. So they had that people to speak to. We had a set of chaplains on staff for our crews to speak with. And there's a big push in the cities, especially when I was there, for the use of the CISD teams, the critical incident stress debriefing teams, which had individuals and who actually were prior police, fire, EMS nurses who had gone through some of these to some extent, who were able to then not share their experiences, but almost proctor the discussion amongst providers and give us that framework to talk in amongst. One of the most important aspects that I found with that too is like another unfortunate co-sleeping incident that I was involved in that was again unsuccessful. I remember walking away after that call and going, we just worked on this kid for 40 minutes to an hour. I wasn't the main provider. I ended up being the one driving because my partner was providing care in the back. And I never knew the gender of the kid, despite the fact that I was doing depressions on them. And I only found out afterwards what their name was and what their gender was. And it was just something that I had no idea. They were a baby and they were a patient, and that's what I knew. And that was all I knew about them. And that meeting gave me some of that closure and filled in some of those gaps in my memory that can come with those stressful incidents and provide everyone a timeline. Because I think that's one of the most important pieces, is filling those gaps in memories afterwards and making sure that everyone has a full picture and all their questions are answered. So we're not walking away with any what ifs, what happened, what if I had.
So you mentioned the cities, which I would argue that the cities being Minneapolis, St. Paul, they have a tremendous system. I've gotten to know a lot of the medical directors from regions, from Hennepin. I've started to get to know some of the ones from Mayo as well, and they're all phenomenal human beings who have huge hearts for their ALS and BLS as well as their flight crews, for sure. How do you, in your experience with doing rural stuff, do you feel like there's a paucity of that kind of stuff? Is there a lack of that resources? Have you heard of anything like that from where you're working now?
I haven't heard of anything that exists in those regards. I also haven't been part of any of the calls of higher emotional load, so I don't know for a fact.
Regan, what about you? In your experiences as a EMT, anything like that you can think of from both an urban and as a rural perspective?
So yeah, I worked both rural and urban, and initially I think the difference was pretty dramatic. And I understand, Jason, like when you're kind of in those urban areas, there's a lot more resources, there's a lot more support. It doesn't make these calls any easier. But my first really rough call was out in the sticks, out rural. And we had like 2 kiddos who got into a jet ski accident, and one survived and one didn't. After that call, one of our partners that were with, there was actually 2 rigs that came out there. And the lead just said, tough night. And we all just went back to base and started doing chores again. Like nobody talked about this. And I remember going home and trying to process what was happening. And this was very early on. I was like this little baby EMT. I didn't know really what I was doing. And I luckily had a couple days off there, but for an unlucky reason, I just had all the time to sit there and think about it, and was awake for about 38 hours straight just because I could not fall asleep because I was just thinking of the patients. Luckily, my partner is also in healthcare, and he recognized the signs of things before someone was able to hand me a sheet to tell me to recognize these signs. And I'm very lucky that I had him to kind of help me through that. But no one told me what would happen after a call like that. And you just tell yourself, you're like, oh, it's the job, it's supposed to be difficult. But then it just starts affecting your personal life, and you don't take care of yourself, and everything can spiral after that. It's different out in the rural areas. And I do see it getting a lot better. I've had tough calls later on where we immediately debrief, we talk about it. If we feel like we need to text a partner and say like, hey, I'm going to come home after this shift and it's going to be difficult. If I can't talk about it, here's my medic's number so they can just warn you what happened. And there was a lot more support that built during my time out rural, but it definitely was lacking at first. And I unfortunately think that might still be the case in a lot of areas.
I think this gets to the heart of what we really want to talk about tonight. And I'm going to express a thank you to the medic who reached out to me just today to talk about what they are currently experiencing after a very difficult trauma. And I'm going to bring up the questions that they raised to me in particular. And there were 2 questions, and I'm going to paraphrase a little bit for what they were asking. Question 1, and we'll then open this up for discussion, is how does one deal with what they described as the adrenaline dumping that happens? So you go to this event, whether it was something that you went through, Jason, or you, Regan, you have all this stuff happen. It's hugely traumatic for not just the family, for the patient, but for you all as well. And then you have all this adrenaline. You're on this high, especially at 3 a.m, where you've been sleeping, you get up, your blood's pumping. There's no way you're going back to sleep if you're going back to the garage and trying to get an hour nap or whatever. And even after the fact, case in point, as a resident, I coded several patients, and it was, 4 a.m. on a night shift, and I went home and I couldn't sleep for hours. Like I would probably up most of the day and I had to get back for night shift again. Like that's what we're defining as adrenaline dumping in this context. The second question that I think we've already alluded to a little bit from what Regan was saying is how do we deal with that back to work mentality? And again, we're all about trying to find solutions, not place blame. But I know classically one of the most common scenarios is, well, the administration told us to get back to work, or the administration doesn't care, or they're not out in the field, they don't understand this. So I'd like to take a little bit of time to unpack for sure those 2 things, and then we can kind of see where that leads us. So let's start with the adrenaline dumping piece. How do we, as pre-hospital staff, first responders, EMTs, paramedics, the medical director, how do we approach the idea of adrenaline dumping? Is there a correct way to do it?
If there was a correct way to do it, I don't know if we would still be like having the conversation. I wish there was a correct way to do it. Everyone is going to experience that kind of fall from that adrenaline completely differently. Like most problems that people want to face, the first thing is figuring out what it is, when it's going to happen, what it feels like. And that can sometimes take a second to feel that shift that actually happens once you get back into the rig, once you're back at base, once you finally get home, or once the next dispatch comes out, where everything kind of shifts in your own head, in your own body. But one thing that's really helped me with it, and maybe I just got really lucky that I always worked with partners that I felt comfortable doing this with, but I would just be open and honest about it. And when we would get back into the rig after a call, I remember most of the time we would just sit in absolute silence, maybe every once in a while someone's charting, they're like, oh, what was that second set of vitals? But otherwise, it's just silent. And whenever someone was ready to start talking about it, it usually started out with a little humor, because a lot of us get through this with some dark humor, but you just start debriefing this or saying like, well, that hurts now, or I just cannot believe that just happened, and just start getting it off of your chest, because we know that bottling up doesn't really work. But also, unfortunately, the dispatch might give you a call 5 minutes later and the bottle might just need to be sealed for a second. But it should never be held onto very long before you at least share it, especially with someone who also just experienced it with you. It's always nice that, at least for the majority of time, you're not really going into the field by yourself. I've had cases, but you shouldn't be in the field by yourself. So you always do have that one person, at least, who semi understands what's going on.
And I think you hit on a key point, Regan, is this idea of debriefing in some shape or form. I am a huge proponent of including our EMS with the hospital staff, so that if they bring in a coding patient, a trauma, whatever, something that is high acuity, unstable, high probability of mortality, or just someone that needs a higher level of care that needs a flight crew, I think it's really important to be sure that even if they're not part of the quote unquote hospital staff, they're still part of your team. And that's something that I've been very transparent about since I've started working where I do. Even though the EMS service is not employed by the hospital, they are part of that hospital team in that moment. And I expect them to be included, because not only is the physician, the nursing staff, the tech, the phlebotomist, the radiology tech, they're not the only ones that are going through survivor guilt or going through the mental gymnastics of what could I have done differently. The EMS crews are going through the exact same mental gymnastics, and there's less of them and there's less support, especially in the rural setting. So being able to pull them in, walk through the scenario step by step of EMS got to scene, this is what they saw, this is what they did, this is what we did once I got to the ER, just processing step by step and making sure that that we build up each individual, whether that's the medic or the nurse, et cetera, and just saying like, you did this really well. And because you did this really well, you gave that patient a fighting chance to survive. Now, if there was a point of contention or something that does need some constructive criticism, that needs to get brought up during that time as well. Because again, we want to try to get as much off our chest as we can to say like, I'm not sure I put that IO in the right spot. Well, actually, we flushed it and it worked just fine. Those are conversations that we're trying to get ahead of to make sure that before you leave or before you go back to your shift, you can go back to the ambulance bay, you can go back to bed, or whatever. You can say, I did everything I could, or I missed this step, but we still gave it our absolute best. And I think that's the first step. And an example of a situation we had a while back, we had 2 brand new EMTs on a call with 2 medics of an absolute disaster situation. And the EMT had a really hard time with that because they hadn't seen death before. I know that my lead medic spent several hours with that team walking through it, talking about it. So having that experienced medic, having that experienced EMT, calling one if they're not on, calling your medical director to say, hey, this just happened, let's talk about it. And I would argue that if you have the capability, that does raise the question of, do we need to take this group offline for an hour and call in the backups just so that if something happens, they've got more time to process so that they're ready to go for the next one? And sometimes that's not reasonable. You're in a small enough town or a small enough community, that's all you got, then you're kind of stuck. But I think that's one aspect that I think is really important. The medic that posed this question to me originally said that for them personally, they go and get a pump in, go work out, go for a run, stretch out. They talked about how when they were doing their resuscitation, their muscles were sore. And the next day, their muscles were still sore. So it's almost like a muscle memory PTSD like situation of my body aches because I just had an impossible code the other night and I still am trying to process it. So I think physical fitness is a good example. Like whatever you have that's constructive, reading a book. In my case, it was play video games for several hours just to decompress myself. There's not a bad way to deal with this adrenaline surge. I think the worst thing you can do is not talk about it. Or if we start passive coping in ways that are destructive, put your own life at risk and put your patients at risk. Jason, any thoughts on what we've talked about so far?
Yeah, I think Reagan hit it really well too, right at the beginning when she said everyone copes with these in different ways. And if there is a good way to do it, I really hope someone would tell me at least because I could use it. I know that I kind of have the opposite of adrenaline dumping, where I get really big on the dumping part because I end up sleeping for about 24 hours after a good adrenaline dump. I don't know if you want to call it luck or fortunate enough that all of my bad calls happen at the end of my shift without fail every single time. So I can't speak to the going back to work part because I was usually held after by a couple hours when mine happened. One of the best pieces of advice I was given right from the get-go was, you're going to want to drink, don't. It was like, I don't, and especially when I was like 19, right? I didn't drink a great deal legally. I called my then girlfriend, now wife, and she didn't quite know what to say. And I don't blame her for that, because what do you say in a situation like any of the ones that we've described tonight? And I started getting angry just on the fact that you didn't get it, but at the same time, I'm grateful you don't get it. And I called another friend of mine who was a medic, who I just found out that night had also never had a peds arrest, and as such also didn't get it. But having someone else who was in a similar role as you and talking with them about it was as beneficial as I think I could have had in that minute. So building those friendships and building those relationships with your partners and having that ability to say, like, hey, I need to talk about this for a second, and knowing that they'll drop whatever they're doing at any minute of the day to talk with you is hugely important and hugely impactful for getting through this job, I think.
Adjacent to that, I agree. Don't go and just drink after these shifts, but do go and drink water, eat food, change your shirt if you need to. Like, these physiological needs can really help your body also just cope with what's going on. And I think that's one thing that went really wrong during my first bad call is I just went home and thought about it and didn't eat and didn't drink any water and didn't take a shower after that shift and couldn't sleep and just sat there in all of those feelings. And there's something to be said for just reminding yourself that you're a human, you need some things too. And from that point on, there was always like an emergency snack in the rig. There was always an extra bottle of water in the back. And it just kind of helps to just reprocess your brain and be like, okay, I need a few things here. I know my partner probably needs a few things here. Now let's start talking about these things. And unfortunately, if you do have these calls at like the beginning or middles of shift, which has happened and it's difficult, but if you kind of reset yourself a little bit, it makes it just the tiniest bit easier to go back to work, but it's definitely one of the harder things that you'll have to do.
So I think this is a good transition point, as we've talked a little bit about the after already. Let's think about it in the context of the next 24 to 72 hours. I think, like we've said, talking to other people in the medical field who get it is a very great starting point. I know talking to Phil tonight before we did this episode, he said the same thing. Some of the best things he can do after a bad call is call someone and just talk about just like basically doing your HPI in med school. It's like basically presenting the case, if you will, to someone else so they can hear you, so you can kind of unload that thought process. But I think the other thing that we're starting to see more of, because we think of PTSD, even like 10 or 15 years ago, was a war only thing. And again, not diminishing what our vets have done overseas, but some would argue that some of the things that people in pre-hospital EMS sees can also cause a PTSD-like situation. Case in point, getting handed a sheet of paper saying, these are the signs and symptoms of really bad psychological disorders, and just let us know if you have any of them. I would advocate, and being a psych major from college, having a wife who's a psychiatric mental health nurse practitioner, having a future brother-in-law who is a counselor, your mental health is hugely important. And I, as a medical director for my groups, feel like it is on myself that if someone is truly struggling and they feel like they need that additional assistance, that we make sure that we have those steps in place to make sure we can get them plugged in, whether that's going and seeing a counselor, seeing one of the mental health experts that can prescribe medications, or as you alluded to earlier, Jason, like just seeing your pastor, seeing your priest, like talking to someone else that can kind of address the mental health and the spiritual component. Because as far as those wavelengths go, it's a lot broader spectrum for everybody, right? Like not everyone's at the same place. So it's probably hard to find someone that meets you at that mental health component or that spiritual component. And so having another place you can go to further decompress, to further acknowledge that you're a human being. We are not robots. And that's one of the biggest hurdles I think that we see from an administrative perspective, right? Like the perception for those of us that are providing the healthcare versus the ones that are in the office making the choices. We are given protocols, we are given expectations of what our job is, and we're supposed to go do them without question, that we are to follow those protocols to the letter and go back and do it again and do it again and do it again with no active thought process of, oh, that's right, these people just had 3 really traumatic things. Maybe we give them a break, or maybe we just like have someone touch base with them. And I think this is a problem not just at a level 1 trauma center. This is a problem in the rural setting too. I've kind of already set up the situation, but do you have any other additional thoughts related to aftercare, if you will? We've already kind of talked about like what to do in the initial hour or two after, but what does aftercare look like to the rest of you?
Hey all, Phil here. I thought this would be a good spot to sort of jump into the conversation for a minute. Agree with everything that's been said so far, some fantastic pieces of advice. For my side of it, 13 years in the pre-hospital field in mostly the urban environments, I would say definitely prioritize self-care. Sleep is huge. I was always told that a good workout, whether it be a walk or an actual like full-on lifting session, was also huge. Some of those physical manifestations of stress can be sort of productively channeled through a decent workout and some sleep and a hot shower. And that way you're not dealing with both the mental and the sort of physical manifestations of some stress. So that's huge. Making sure that you pre-offload some of these feelings before they pressurize and build. If you think about like a pressure cooker, it's much, much, much harder to tear the lid off of something that's pressurized than something that's releasing pressure here and there. And that happens long, long before an incident would ever occur. You want to get in front of anything that would happen to you in this job. And the way you do that is by making it a regular practice. Before you get the really hellacious, stressful calls, practice on some of the less stressful calls. Practice sharing, find out who your network is. Not everybody is the best person to share with. Not everybody can really listen in the way that you're going to need them to. And so you want to identify those people in your network who are those resources. That's huge. In terms of sleep, I think we don't prioritize sleep enough. Obviously, as paramedics, EMTs, first responders, we sleep weird schedules. We do all kinds of things to our bodies that we probably shouldn't. But particularly after a tough call, tough day, sleep is huge. You are going to get a host of very furious pieces of information coming at you, and they're going to stack up in your brain, and you're going to need time for all of those things to be filed away. So like Regan said, a nice bottle of water and a few hours of sleep is definitely important. That's the way I sort of definitely make sure that I'm prioritizing those things after tough calls, in addition to my close-knit circle of support. So just wanted to throw my 2 cents in there.
You know, in the immediate afterwards, like I mentioned, those physiological needs are really important. But sometimes, like you said, you have these 3 traumatic calls back to back to back, and you need to be at your best for every one of them. And this is something I've learned a little bit more inside the walls, but I still think would have been very helpful to practice when I was out on the rig too, is literally shaking off the call. And I would do this and sometimes in the ER, and I would always have to be like, okay, make sure no one's in the hallway. But I would literally walk out of a patient room and just like shake my hands and like get it off and just be able to go on to this next call. And while that's a nice Band-Aid to help you get onto these next patients that you need to see, that aftercare does not stop there. Like this comes home with us. And that's a really unfortunate part about working in these higher stress jobs, such as healthcare, is it really does affect your personal life. As I mentioned, I'm really lucky that I am married to someone who is also in this field. So I can come home and I can continue these debriefings with my partner who's had, if not a similar crappy day, or knows what it's like to have those days. A total flip side of that is sometimes it can be extremely helpful in that kind of like post shift aftercare to remind yourself of happy things. Whether it is like just going and getting coffee with a friend and not talking about work, or taking your dog out on a walk and literally smelling the flowers, like anything that can kind of show you a little bit of beauty in the world, because unfortunately our jobs show us some of the hardest things that the world gets to see. And I hope to learn a couple more because these things continue to hurt as you have these bad calls. But for right now, that's what's helping me get through. I hope Jason has more because I would like to learn.
I was just going to say, off of what you said, Regan, go do things that are good for you, but don't let your spouse talk you into going and looking at kittens because you'll end up with one. I fell into that trap. The next 72 hours, I think, are huge, especially in building that mindset on how you're going to be for the next week. Talking with those friends and going and spending that time. Dr. Collins, sounds like I have a fairly similar version with you, playing video games, but where I was living before and stuff with where my friends were, it was one of the few ways I was able to keep in contact with my non-healthcare friends and draw your attention away from something that isn't healthcare. Especially with the rural communities and working in your community where you're on call, I think you could also fall privy to everything else that is still happening. Your pager still goes off whether or not you're having a bad day or not. And if you can, I would probably largely encourage you to try to pass your pager off to someone. See if you have a good friend who is willing to take call for you for a day or for a night. And just so you can have that breather and not focus on the emergency side of things, I think is huge.
The other thing that I'm really big on, and I know you indeed taught this a little bit, but I think it was taught in a way that was almost distasteful at times for us in medicine because we had everything else going on, is the importance of interdisciplinary interactions. For example, I know that in some situations, my medics reach out to the nurses or to the DON and vice versa, because checking in with each other, right? Because you've all gone through this trauma together. So even like 36 hours on the road, I texted after this recent tragedy, I reached out to all my medics and my EMTs and said, go get a coffee. Go to the coffee shop, tell so-and-so that Dr. Collins is paying for it. I'll take care of it. And I did the same thing for the nurses. I did the same things for the techs. I did the same thing for radiology and the same thing for the lab because they're all in it together. And the more we can normalize that this is a team sport, you don't solo medicine. I don't care who you are. I don't care how smart you are. I don't care how cold and detached and sociopathic you are. You are part of a team. And so when the team is suffering, you need to work together as a team to go through it. And that doesn't mean you need to sit down and have like 2-hour therapy sessions, but just checking in, like bringing in a patient the next day and just saying, hey, we were at that code the other night. How are you doing? I think that speaks volumes, especially the rural setting, because these are people that you're going to see every single day or every other shift compared to bigger institutions where you probably don't have that luxury as much. Like, yeah, you still might see people that you know or that you're familiar with, but I think that relationship in rural EMS is more, dare I say, intimate in that regard. It's more personal for sure. I think that's another component that I try to espouse to, my medics and to the nursing staff when I'm on shift, when I run a code like that, is just trying to remember that we're all on the same team here. We need to make sure that we're looking out for each other.
I think that's an advantage too that rural EMS has over more urban size ones. Over my almost 5 years in the cities, every shift I could go up to 7, 8, 9 hospitals. During my time there, I probably got on first name basis with a handful of nurses, a couple of doctors. In that same realm, with my very short stint up here, I've gotten on a lot more first name bases with a lot more nurses. And I see them over and over and over again. Even if I'm working 1 shift a month, 2 shifts a month while I'm in school, it's still the same individuals and the same hospital. And it's not 9 different hospitals with 50 different nurses apiece and, a handful of doctors that rotate through. So there is that feeling from what I've gotten of a team approach and a team atmosphere. And we're all in this together.
So circling back to the last bullet point that we're going to cover tonight, because we've already gotten about 40 minutes into this conversation, and this will undoubtedly be a 3 or 4 part segment, if not more, depending on what feedback is. And if those of you who are listening are saying, hey, what about this? Or what are your thoughts on that? Like, this is what this discussion is for, is to open that door that I think, especially from the rural perspective, many medics and EMTs are afraid to open, because historically rural EMS were the cowgirls that are tough and nothing phases them. And that couldn't be further from the truth, because these are our communities. These are the people that we see every single day. These are our teachers, the people we see in the grocery store. These are the people that work at the coffee shop. These are our librarians, et cetera, et cetera. So I think that's very important to keep in mind. Let's walk into the last step here of what quote unquote back to work looks like. Let's say that we're in a situation where there's this pressure for you to go back to work and you're not ready. How would you each individually approach this? And then I will speak from the perspective of a medical director. I don't consider myself an administrator. I'm someone that writes protocols and just make sure my medics and my EMTs are doing okay. Like, it's not my job to push a pencil or push some paper across and tell people what to do. My job is to make sure that everyone's doing the best care that they can.
It's definitely shifted throughout my time, both out in the field and in the hospital, but focusing kind of on that field side. And like I said, I've worked rural and urban, and the resourcing is going to be a lot different. So I've been out in the rural setting where you don't have backup, or you're covering 2 towns already because the other 3 rigs are all doing transfers into the cities or into a bigger hospital or to a designated center, and you're just parked out in the middle of nowhere after a traumatic call waiting for the next one because there's no one else to cover you. Those are the times that it's extremely difficult to get back to work because it's so immediate. Dispatch does a really great job of checking in and saying, are you ready to go back? Are you ready to be off scene? Are you ready to leave the hospital? But when it's just you covering these 2 towns, that call is kind of being made for you. And you can cross your fingers and hope nothing is going to happen, and you can sit there while you're still on and talk about it and try to get your head around it before the next call comes out. But in areas where you at least do have a backup, what I've found is really nice when the other rig says, we're going to cover you guys for a second, or have yourself still on scene. We'll cover the town and give yourself 10 minutes, regroup, grab food. If we need you, we'll call you. If you have that support and that structure in your service area that allows for that, and we had that support from our director, saying if that was a tough call, there's another rig in the service area. We run it all the time where there's one rig just covering that whole section. It's okay if one rig does it and the other rig is just figuring out how to get back onto shift. It's okay to ask for that, but it's really nice when it's offered to you. And so my partner and I always tried to make the effort to know what calls were going on and to say that sounded really bad. We'll cover you guys for a little bit. Let us know what you need, or come back to base. We'll all have dinner together. We can help you out. But it is a little bit of a luck of the draw, especially in some areas where there's not as many resources. And while that might be something that we just want to fix, like systemically, that's not going to happen in 2 days. So figuring out what's best for you to kind of bounce back. And it's like I said, it's going to be different for everybody. For me, I just need to chug a bottle of water and eat a snack, and I can usually get on to this next call before that shift ends, and I take that time. But for other people, it might be go run 4 laps around the rig, get more energy off, and then you're ready for this next call. I don't know, Jason, other insights? Because I think I'm just wishy-washy and saying there's a bunch of ways to do it.
No, I think you covered some really good points. I would say that absolutely. It's one of those things that you hear is that it's really nice when those resources are already available for you and that they're not having to be sought for in the minute. Especially when you're talking about this situation where we have a call that's potentially pending and we're at the end of this awful call and we need a minute. If we have other crews that are willing to cover for us, and if you're at a service, I'd say that doesn't do that, start doing it, because you're going, as if one person makes that change, it's going to help change the whole mentality of the department about, hey, they just had a call that sucks. Let me step in for them. And from my background, I'm used to working with lots of trucks and having tons of crews that'll step up for you. And you could always tell the people that would, because everyone would also be jumping at to help them out when the time came that they needed that help.
I'll close this from the perspective of the medical director. I fully agree with everything you're saying. My obligation as the medical director is to make sure that my people are protected. If there's a service that I inherit or there's a culture change or something like that, where quality of life, being able to recover from a really bad traumatic situation is not present, I would want to step up and make sure that we make meaningful change or try to encourage a culture of change in that regard. And sometimes it's important to keep in mind for those of you out there that your medical director doesn't see what they don't hear. So if I'm working in the hospital, doing my shifts, doing my other administrative duties, I'm not always attuned to everything going on in the ambulance garage. And granted, the ambulance garages are a lot like high school sometimes, in that there's going to be personalities and stuff, and you might not like somebody. And we get that. That's life. That's true in any profession that we're in. But it's a whole nother conversation to say, hey, this person got crushed the other night by 3 really terrible things. We want to get them off service. They're refusing. It's my job as the medical director to step in and say, hey, I heard this stuff happened. How are you doing? Let's get you some time off. You've got your friends and colleagues that are here to back you up, that want to support you, and they think the best place for you is off the rig tonight. Like that's where my role comes in. Or if I come into an environment where the mentality is it's their shift, they're going to cover it, it's my job to try to push back and say, well, why is it that way? What would happen if this was you? What would happen if this was your friend? Would you not step up for your friend in this situation? Like, let's change the culture. Because if this person burns out because you're saying they're supposed to work 4 straight, then all of a sudden you're down another medic or you're down another EMT. Like, we need to be a culture of support and reassurance. And that's where we can make change within the building itself. You could get into the administrative sphere all you want, but ultimately where our ability to make change happens is in that garage. And it's what your medical director can provide. And then your medical director is supposed to be your face. It's supposed to be your PR guy, your PR girl to go and tell administration, hey, this isn't working. We need a better plan. And then my job is to provide solutions, not just say fix it administration, because that historically gets us nowhere. What I can go do is say, hey, this is the problem. I've got 3 solutions for you. Do any of these seem more palatable for you? And that's where you start. Now, certainly it might not get changed overnight, like you said, Regan. Like, this is a problem across the United States. It's a problem everywhere. But what we can do is try to take care of our people and try to change it one shop at a time rather than trying to do sweeping change. Like, it's great that we've got the state chapters, the national chapter of NAMSP, the SEMSO, et cetera, that is advocating at their state levels, at the national level. But those changes take time, and there's no guarantee it's going to go through. So what you can do in a more immediate setting is stand up for your crews and say, this is what I'm able to do for you right now. Let's fix it, or let's make this better.
I'll close us out with 2 little things. 1, do not be afraid to ask for help. Things are changing a lot, and there's a lot more options nowadays. There are services that you can text only. There are virtual counseling services. There are inpatient services. Therapy can be very scary until you're in it. And on those same lines, medications can be really scary until they're helping you. Do not be afraid to ask for help. And a second, more lighthearted part is thank you to Jason for joining us and sharing his insight, because we absolutely love and value it. It's always helpful to have another mind on here, and especially one that has so much experience. So we really appreciate you joining us. And with that, may your mayhem be well controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible.